Okay, I suggest we begin. צהריים טובים לכולם. Good afternoon, everybody. It is my extreme pleasure to introduce the first monthly lecture of the Tel Aviv University Center for Combating Pandemics. And our first lecturer is our own Dr. Dan Yamin. Said our own because he's a member of the leadership of the center. And Dan will talk to us today in English, as we promised, about human mobility and poverty as key drivers of COVID-19 transmission and control. I will briefly introduce Dr. Yamin. So he's a young faculty member in the Faculty of Engineering, the Department of Industrial Engineering, and a former member at the Center of Infectious Disease Modeling and Analysis in the School of Public Health at Yale University. Dr. Yamin's studies contributed to impact health policy against influenza in Israel, offered novel strategies to eliminate Ebola that were implemented in Liberia, and recently developed a model offering new vaccination strategies against respiratory syncytial virus, or RSV, that is currently being examined by world-leading vaccination companies. More relevant to the lecture of today, Dan received the recently European Research Council, or ERC, grant to pursue research on the early detection of infectious diseases using smartphones. So this is related to today's lecture. He recently advised the Ministry of Health and Ministry of Finance to identify hotspots and apply effective strategies against the COVID-19 pandemic in Israel. Dr. Yamin received 4 research prizes, several awards and teaching awards. So he's one of our promising young faculty, and we are all looking forward to his lecture. Now, the lecture will be for about 40-45 minutes. It will be followed by a short Q&A session. If you have a question, please type it in the chat box of this Zoom meeting, and I will present the lectures, or if we have sufficient time, all of them or part of them at the end of Dan's lecture. So Dan, please, the podium or the Zoom is yours.
Okay, so thank you very much for this warm introduction. It is indeed with great privilege to present our work to this interdisciplinary audience. I think that the way I see it, the primary purpose of this talk would be to promote a collaboration between this broad, highly skilled audience and my lab. Thus, in the upcoming 40 minutes or so, I will briefly present the Laboratory for Epidemic Modeling and Analysis. And then I will discuss on our COVID-related projects and the main methodologies that we use. Then I will expand on one specific project. And in the remaining time, I will share some thoughts from my own personal experience when working with decision makers in Israel and the political challenges that I believe we faced. I hope you will enjoy the talk. Being aware of the high skill of the audience and the interdisciplinary fashion, I promise you that I'm not going to show even one equation, but I hope everybody will enjoy and will be curious about the talk. So I will start by briefly presenting myself, because first and foremost, I see myself as an engineer with a background in epidemiology. I did my postdoc at the School of Public Health at Yale University in epidemiology. 5 years ago, I founded the Laboratory for Epidemic Modeling and Analysis at Tel Aviv University. And our main goal in the lab is to harness the power of big data to defeat epidemics. So if you like, most of our work is on modeling infectious diseases, where we utilize medical and non-medical data to forecast transmission dynamics, to evaluate the effectiveness and cost effectiveness of interventions. It could be new technologies, new medications, vaccinations, etc. But with the understanding that not only diseases are contagious, but also various phenomena can be related as contagious, we expand our work to other domains, including viral marketing, social contagion, and cybersecurity. And the interesting part is that we can learn from modeling of infectious diseases to the other domains and vice versa. I'll just give you a simple example, simple demonstration. When it comes to social contagion, we typically refer as social phenomena. It could be obesity, which we might argue that it's health related, but it could be non-health related. For example, anti-Semitism. So just a simple demonstration. Thanks God, in the US, the Nazi groups are not that popular, and sometimes it's hard for them to convey their messages, but they clearly want to communicate with each other. Now, how they do it when we look at the media, how do we do it when they look at social networks? So sometimes they have hidden messages. So if you like, I'll just give a simple example. We, I don't know if you are aware or if you noticed of a cat with a small, nice, so to speak, mustache. And what they do is they just post this small, simple mustache cat nice picture. And you and I think it's really nice and cool. We retweet it. And then the other side get this information, the other groups, and that is how they communicate with each other. If you like, this is what we call asymptomatic infection. And that is the main driver for COVID. So by understanding the reality of the situation that is related to infectious diseases, we can learn about transmission dynamics in other phenomena. Another, I think, interesting demonstration would be related to cybersecurity. So when it comes to cybersecurity, maybe I'll briefly discuss about a previous work related to infectious diseases. So when it comes to infectious diseases, and in particular influenza, when we ask who should be targeted for vaccination, we can say those that are highly interactive, those that have a lot of connections. And if you think in terms of a network, a contact network, we would like to identify those at the network that seem to be the centrals. Now, realistically, we cannot ask an individual, hey, are you a central in the network or not? But when the idea that we had is that individuals that infected in the prior years, they're more likely to be in the pool of those that are centered. And because of that, they have a higher risk to become infected for flu. And thus, they should be targeted for influenza vaccination. To make the long story short, we utilized the network modeling and data from Maccabi and Clalit, and basically showed that this population that got infected in the prior year or that were reported with ILI illness are substantially more likely to become infected and to be reported as infected in the upcoming year, and especially when it comes to complications. This notion was even became a policy specifically in Clalit and also in Israel by the Ministry of Health. And by understanding this conception, we basically developed a network to try to identify elevated risk to get into risky URLs, and it was highly successful. So the simple notion of thinking about a network that considers prior infections, when it comes to cyber, it was getting into URLs that has malicious apps, will be a very good proxy for future risk. So if you like, infectious diseases is the infection of our body. The social contagion of viral marketing is the infection of our mind, and the cybersecurity is the infection of our bots, so to speak. And if I think about one thing in common for all four components, that would be the human behavior. And in this note, I should say that maybe 20 or 30 years ago, one would argue that the laboratory for epidemic modeling and analysis should be in the School of Medicine. But nowadays, it is clear that in order to improve our understanding on transmission dynamics, we should improve on our understanding not only on the biology, but on human behavior, and I would argue primary on human behavior. So in addition, to utilize medical and non-medical data of large scale and to think in terms of the interdisciplinary fashion, the application is the most important thing when it comes to policy determination. And as such, the Faculty of Engineering seem to be an ideal candidate to host such a laboratory. Now, just to zoom in, the talk for today will be on infectious diseases, specifically on COVID. So let's move on to our COVID-related projects. I will present them in accordance with disease progression. So first, as a result of an interaction with infected individuals, an individual might get exposed to corona, then he or she might suffer from or will move to a stage that is called the incubation period, in which symptoms, clinical symptoms, do not appear. We know that for those that eventually will have symptoms, a day or 2 days prior to those symptoms, they are likely to infect. So they have a sufficient viral load that will enable them to transmit the disease. For a portion of the population, they will show symptoms. For a portion of the population, where it comes to COVID, it's a portion, and as time goes by, we understand that it's unlike to what customary to think. Only a portion of the population will seek for care, or even before, they will ask to be tested. And then a portion of them will suffer from severe outcome, hospitalization, and death. And if we think, what is the most important problem? What is the problem? It would be the severe cases. So our first project would be to try to predict severe outcomes. So for this, we're utilizing data from hospitals, where we develop machine learning algorithm that predicts the deterioration of individuals based on their clinical records and based on the records that we see in the hospital. But maybe that is too late. So we ask ourselves, can we help in other forms? Maybe we can help earlier. And that is why we used Maccabi data in order to see if we can predict before the individuals even got tested, they asked to be tested against COVID. Can we say something? Can we forecast the probability? Can we forecast if they eventually will be identified with COVID or not? So the premise of this work is that by understanding who will eventually become infected and who will not, we can help in many aspects. One of them would be in pool testing. Another would be to help the system better utilize the capacity, etc. And the interesting part that we saw for this project, that we can look at their symptoms, the clinical symptoms that the individuals report just before they're being tested. And that gives us quite a lot of the understanding if the individual will eventually be found positive, but also the region of the individual and his or her clinical records of the past 10 years serve as a very good marker, as a very good predictor if he or she will be found infected. For example, individuals that are vaccinated for flu, especially those who are vaccinated early in the season, they are less likely to be found positive. The reason for that is their behavior. They are arguably more likely to protect themselves. And because of that, we can see that when they are tested, they're less likely to become positive. So I think this is really fascinating. This study has not only policy related aspect, but also some research background that I think we always neglect, because when we look at medical data, we try always to say, hey, these are the factors. We know that when somebody has flu, he or she is more likely to have these kind of symptoms. But there are some confounding factors. But if you like, we can call them predictors that can help us in the prediction task. But we ask ourselves, maybe we can help a bit earlier. And for that, we're working on a large-scale project. This is a part of the Israeli Science Foundation as part of the Precise Medicine, Rama Refuah Mutemet Ishit, where we conduct a prospective study and ask individuals, 5,000 individuals, to give a consent that we will utilize their medical records and integrate it with our #1 addiction, the phone. Think about it. When we go and we seek for care, so the truth is that our meeting lasts on average 7.6 minutes. The median is 5 minutes. And this is, by the way, not different in the vast majority of the developed countries. Maybe the exception is Sweden. But the bottom line is that it's a very short period of time where the physician makes the decision or the prognosis primarily based on the clinical signs and symptoms that he see in a one static point in time. By contrast, although flu and RSV, for example, seem to have similar symptoms, they have a totally different patterns in terms of the appearance of the symptoms and other habits that we might be able to learn by using the phone. So we developed an application, a phone application, and we ask individuals several questions, and we also take or analyze passive data, for example, steps, GPS location, etc. But we asked ourselves, okay, but can we maybe help a bit earlier? And for this, we are utilizing also a large data, non-medical, so to speak. We equipped 5,000 participants with smartwatches, with wearables, and we try to see, or I should say the notion, the premise of this work is that we try to distinguish between what we call the digital symptoms and the actual incubation period. Because change in heartbeat, change in sleeping habits, that is a clinical symptom. But for the most part, it is not being identified by the individual. So it shouldn't be clearly stated as incubation period. So it is possible that the actual incubation period is much shorter when we account for the digital, or if you like, invisible symptoms. And this is going to be by following the 5,000 participants for 2 years and integrate this data with the mobile data, with their electronic medical record, of course, with a clear consent from the individuals. But we ask ourselves, maybe we can do it even earlier. Maybe we can identify hotspots to develop controlled strategies, and this is funded by the Zemin Foundation. So if you like, the overall methodology is to utilize non-medical and medical data and identify visible and invisible symptoms, not in one static point in time, but in a continuous, so to speak, time, even before the individual got infected. So if you like, Amazon typically tells us, you know, you bought this book and another, or film or whatever, and we know that individuals that typically purchase this book, they're more likely to purchase another book. So we'd like to recommend you on another book. So this is what we want to do. We would like to recommend you on an infectious diseases. So basically, so to speak, you can say, hey, there is a similarity and we can learn about the individual's behavior using the medical records and using these tons of data. And by that, understanding this behavioral component together with the medical component, we can see the similarities between individuals that will enable or help us improve our diagnosis and ideally make things earlier, and that will be helpful in order to break the chain of transmission. So this is in a nutshell what we're doing. I think even I'll just say one more word about clinicians that, you know, to the most part, what clinicians forget about infectious diseases when trying to detect an infection is that they're infection, that they're contagious. So if in a specific region, there are a lot of people infected with RSV and somebody asks and seek for care, he's more likely to have RSV and not flu. So by understanding the transmission patterns, we can, of the population as a whole, we can get a good understanding about the diagnostic thing that is often being neglected. So returning to our COVID-related projects, we will focus today in today's talk on this, identify hotspots to develop control strategies. So one would ask, first I will just introduce the data. So the data that we received is from a large cell phone company. It has over 3 million users from one of the largest communication companies in Israel. And the data is aggregated and anonymized. And I'm very happy to say that because it is in accordance with the GDPR. We have no ability whatsoever with this data to reach the individuals. And I think in a situation where we hear about Shabak following us, and to the most part, I would say that unfortunately in this pandemic, we see how great is the privacy violation that is being done. So here we don't we don't introduce any, we don't have any issues of privacy violation. The data basically specifies pattern or mobility patterns within and between 2,630 zones covering Israel. So basically we sliced Israel into 2,630 zones. And what we have is moving between one zone to an hour, and to make sure there will be no option to identify the individuals. If we have movements of less than 50 people, it is set to 0. Okay? Now, this is a challenge because we are using aggregated data. And the question is, what can we learn from aggregated data? Can you please make sure that you're on mute? I think I hear some voice. So what can we learn from aggregated data? I would argue everything. This is just a simple demonstration of Mount Meron, okay? And what you can see in dashed, you guessed it right, this is Lag BaOmer. So we would expect to see a spike in the number of visitors in Lag BaOmer. But in fact, we didn't really see this spike. But 2 days after, for some reason, we saw a very high number of visitors. First, we thought that there was a mistake, but then we realized that here the police just were aware of the fact that there might be a congregation, so they closed the mountain, and then they opened it a day or two after, and that's what we received. And then these people went to their specific zones, and then boom, that is how you can identify infection. So if you like, you can learn everything. That's what I would argue from the mobility. So this is February, before COVID, okay? And we compare the data to this baseline, February before COVID. This is the first national closure, okay, the lockdown. This is the second lockdown. It is smoothed data. You can see visits that are below, visits out of home that are below 2 kilometers, between 2 kilometers to 5, 5 to 10, and over 10. And we can see here Pesach. We can see here how we gradually opened the market. Here we can see Shavuot, and here we have the vacation, the חופשה גדולה, חופש הגדול, school vacation. And then, you know, typically people in Israel, they like to go and visit and have some trips just before September. So we can see that over 10 kilometers, we can see a rise there. This is the second lockdown. So we can learn quite a lot just by looking at the mobility data. But
Dan,
okay.
Dan, can we ask a quick clarification question?
Of course.
So where did you get the data from, and can you share it? Is it, you said that it's not related to the Shabak, so what is the source of the data?
So as I said, it's part of a large telecommunication company in Israel that they asked not to be, not to mention their name. The data is provided for research only. About sharing the data, I mean, as part of the research, and obviously with their acceptance, I think it would be possible, yes. And I think that is part of today's talk. We are having access to great data. We are asking a lot of questions, but you guys know more about a lot of other issues, and I will be very happy to collaborate. So
Fantastic. Thanks a lot.
Sorry?
I'm saying fantastic and thanks a lot.
Sure. Okay, but I talked about mobility, but what about transmission? So before I explain this graph, I would like to say we have to be careful. We have to be careful about non-causal effect. We have to be careful because the fact that an individual mobility change doesn't mean that he has a higher or lower chances, doesn't necessarily mean that you have lower or higher chances to become infected. But very interestingly, we can see a very clear correlation with a lag of 12 days between the mobility, or if you like, the proportion of people that goes away from home for 1 kilometer or travel for over 1.5 kilometers from their home, and the R, okay? So this is what we observed. So it can serve as a marker for elevated risk for transmission. But on the same note, I would say that obviously, if it's a rainy day, you'll also have some reduction in travels, and in that case, that is likely to increase the risk to become infected because we less ventilate, and there are many other reasons. But this was a very interesting results that we obtained. We developed, and when I say we, I have to be to say this is in collaboration with my friend and colleague Professor Irad Ben-Gal and his lab. We had 30 volunteers from the Army, even one volunteer from Rafael, that worked very intensively in a lot of sleepless nights in order to generate our results. Here, what you can see is a system that we developed that gives policymakers some interesting indications related to mobility. We had some ranking about how you say if people follow their restrictions or not. I think maybe, to be honest, we should be very careful when we say follow restrictions or not when we look at aggregated data, but we can definitely, part of the thing that we're doing is try to make things accessible for policymakers. So this is just a screenshot of the system we developed. But in terms of research, what did we learn? So, you know, I would call it the supermarket effect. So it's either when you go to the supermarket, either you see the individual 5 times or you don't see him or her at all. This is the heterogeneity that we can see in Israel. I myself live in Ramat Gan, but I'm not likely to meet my neighbors from Bnei Brak, but I am very much likely to see people that seem to be similar to me with respect to the socioeconomic status and the religious affiliation. I should say that the way we classify individuals based on their religious affiliation and socioeconomic status is statistical. It's based on their the zone where they live in. And as I said, we have 2,600 zones. So in each zone, it's pretty homogeneous. And what we observe is that if you're Arab, you're more likely to meet with Arab. If you're ultra-Orthodox Jews, you're more likely to meet with ultra-Orthodox. The same is true for socioeconomic status. The same is true when you integrate the two together. And I should say it is well beyond the geographical location, okay? And this is what we observed. This is work from March, actually, March, April. And what we observed is that here, this is when we talk about February 13 and March 26, we could see that in terms of transmission, in terms of infection, reported infections, when we classify it into low, middle, and high, it seems to be more or less even, okay? But shortly, okay, in March 27, the result was very clear. It became a disease that is more characterized with low socioeconomic status and particularly ultra-Orthodox and Arabs, okay? And up until today, of course, everybody has risk or might suffer from the disease, but individuals from poorer regions are more likely to become infected, and there are many reasons for that. But this is something that you can see, and it's interesting because we can learn about transmission that basically goes from one region to another when we explicitly account for the mobility and poverty levels. So this is the first part when I talked only about mobility, and when I briefly stated the motivation why it is likely that mobility and poverty predict transmission. Now, we developed an epidemiological model, and briefly about this epidemiological model, that is a mathematical model. I don't show here the equations, but the model was a compartmental model. The individuals in the model are in the susceptible compartment until they're getting infected. Then they move to the exposed compartment, and then at the last incubation period, they might infect. So they move into the eye exposed, and then they can be either reported or unreported, and eventually they are recovered. It is less likely for somebody who got infected with COVID to become infected again. This model, okay, this is the transmission model that we have. What I don't show you here is that this transmission model explicitly considered the age group of individuals and if they are part of the risk group or not. So for every age group, we have 10 age groups. For each age group, we have high risk and low risk. And obviously, we consider the region of the individuals. So it's a fairly big transmission model, okay? But in terms of parameters, we have only 4 parameters. So this is quite remarkable that with only 4 parameters, this is the calibration that we produced. This is the first wave, okay? So you can see we can pretty nicely understand the spatiotemporal, the age structure, okay? This is the temporal, this is the spatio by the districts, 30 districts, and the age. So we can understand transmission by accounting for these 2 components, mobility and poverty. But then we ask ourselves, can we try to help in terms of policy-driven questions? And this is from 5 months ago. We thought that we were, no, actually we were the first, but it doesn't matter. We thought about the Model Ramzor. So we wanted to look at local lockdowns and global lockdowns. So this was done in collaboration with the team from Rafael, where we use optimal control theory. And basically we said, okay, let's decide for a trigger. For example, in a specific region, if we see that there isn't a spike, an increase in cases, the trigger will be activated, and then it means that we will consider a closure or a lockdown, a local lockdown. We also tested global lockdowns. So the basic notion was that we would like to avoid what is called hospital overwhelm. And we ask several questions subject to constraint that we don't want to reach into hospital overwhelm. What should we do? I hope this is clear. So these are the results. We ask ourselves, what is more effective to reduce severe outcomes of COVID? Should we conduct local lockdowns or global lockdowns? The answer was very clear, local lockdowns. When I say effective, I mean that we'll have the same trigger in terms of incidence. Okay, so I say, okay, I have an incidence, I have a specific number of cases, then I ask what would be better, to have a local lockdown in order to reduce severe outcomes or global? And I repeat, local lockdown was far better. And then the question was, what is more efficient to reduce severe outcomes? Okay, when it comes to efficiency, when I say efficiency, I mean that I take the number of individuals that are locked, that have to stay at home, and the benefit. And then the result was even clearer. Local lockdowns are way better. And then we ask ourselves, what is more effective to reduce severe outcomes? School closure or school opening? With no doubt, school opening. Okay? Now, note, our goal was to reduce severe outcome. Okay? So this is in the long run. Okay? But the bottom line is that this disease is so differential. That there is a very high risk for elderly, particularly elderly that are considered from the high risk group, and very, very low risk. When it comes to, if we compare it to flu, then flu is way more dangerous, way more risky for children than COVID. This is with no doubt now. And then we ask ourselves the same question about efficiency and again, school opening. Now, what policymakers did? The exact opposite. So we ask ourselves, how come? How can nobody listen to us? Well, I think I cannot say, hey, this is the right answer for that question. But from a conversation that I had with a lot of policymakers in Israel, especially the Ministry of Treasury I think that their goal was different. So unfortunately, the goal was not to reduce severe outcomes. The goal was to reduce cases, because eventually, and this is the way I see it, of course, you can criticize what I say. I think that there is a very, very high correlation between how people feel towards the government and the number of cases, not the number of deaths. And if you're not convinced, let me just give you some facts. Okay? Every day in Israel, between 3 to 5 people died from passive smoking. But nobody cares about passive smoking. Passive, it's not active smoking. It's people that, and that is why it's so similar to infectious disease. It's people that just share the same spot, that they are close to people who smoke. Now, if we start every day by counting, hey, we have 3 people that died from passive smoking. Tomorrow it's 6, and then the day after it's 9, and we will count these numbers, then obviously that will have a great concern. And that was basically what happened. We saw that we counted the number of cases, and unfortunately we still count the number of cases. And I ask a very simple question: why do I care about individuals that are, for example, in gym getting infected, where they are less likely to transmit to individuals that are more likely to be hospitalized? So I think to some extent, we didn't ask the right questions. The right questions were very clear, because we saw that in the developed countries, 50% of those who were hospitalized were in small regions. They were either got infected in hospitals or medical facilities, or they got infected in Bate Avot, in some community care. So the bottom line was that indeed, if you ask, what shall I do to reduce the number of cases, then you should close school, then you should have global lockdowns. But if you want to reduce the burden, the overall burden, and I didn't even say the economic burden, then the best way would be to think in terms of local lockdowns and school opening. Now, in terms of epidemiological manner, why does school opening make sense? Because when it comes to a transmission, if somebody is getting infected, he's soon to be recovered. You know, everybody is talking about some 2 extremes, either herd immunity or not herd immunity. But I'm not talking about herd immunity here. But I'm talking about the fact that from simple epidemiological standpoint, if somebody is infected and recovered, then the effective reproductive ratio declines. That makes the disease less transmissive. So that basically say that if we try to protect the entire population in the same manner, more elderly and more population at high risk will die. Okay? And I think that the key for policy to work and to deal with this disease is differential. So that is, I would say, the main message that I saw. I think it is far beyond the Ministry of Health and the Prime Minister of Israel. I mean, we can see that the entire world, so to speak, with the exception of maybe Sweden and other, get into the same idea. So they try to think how to reduce the number of cases and not the number of severe outcomes. If you're not yet convinced, I would just like to finish in 2 interesting thoughts. The first is related to the observation that if you cherish life, you have to think about death and how much you are willing to pay to prevent death. And obviously, it is not anything. You're not going to pay everything to reduce a number of casualties. And being aware of that, before the COVID outbreak, all developed countries had standard price mechanism about how much you're willing to pay in order to purchase a good year of life. This is the cost effectiveness methodology. And we know as a fact that developed countries, to the most part, will not pay more than 3 of the GDP per capita. That is, roughly speaking, $120,000 at most to purchase 1 year of life of individuals. And by doing so, we act in an equivalent manner to those who die from cancer, to those who die from any other diseases. And we have in Israel a very important committee, Vadat Asal, the basket committee. And that is what they're doing. They're just working in order to see and prioritize the medications based on many standards. But one of them, I would say an important standard would be the costs. Now, just to give you perspective, okay, the entire money, the entire budget of this basket committee in a year is equivalent to 1 day of global lockdown, of national lockdown. 1 day. So that basically means that we act in a bystander towards COVID compared to any other infectious diseases. And from our assessment, and it's no different than other assessments, we agreed, so to speak, to pay $10 million to prevent 1 single mortality case from COVID when we never done it before, okay, compared to any other diseases. It's not even close, as I said, to the numbers that we were willing to pay against other diseases. So on a personal note, I'll just tell you that the bottom line is, from what I understand, it's not what is right. It's what is perceived as right. And even I myself have to say that about, I think it was in March, I had a simple, there was an interview in Haaretz. And in this interview, I said that I think that the cardinal fact is the case fatality. And at that point, the WHO stated that the case fatality ratio is about 4.5%. And I said that by looking at the data, you can say loud and clear that it is less likely to be 4.5 and that it is well below 1%. And I said that the absurd, that's the way I said it. The absurd is that Trump said that it is below 1% and that Trump in that manner was right about this rate. But you know, what is really interesting is how to sell that. As somebody that is modeling virality, I have to say I got my lesson. They translate this article into English, and the title was, "Trump is right about the coronavirus. The WHO is wrong." After a day, as you can see, Donald Trump decided to retweet. And then at one moment, I became an enemy of the Democratic parties in the US and somebody who supports the Republican. And I think other than this nice story, I think it taught me that the bottom line is that everything is perception. I would like to thank you for your time. And I would like to thank the funders, and the entire team that is working with us. Special thanks to Professor Ben-Gal, Dr. Erez Shmueli, Professor Margaret Brando from Stanford. Thank you very much for your time.
Thank you very much, Dan. This was fascinating. I see that there are no questions in the chat box. This is kind of expected for a very diverse audience. So I'd like to conclude with a few very short comments that are related to the activities of the Center for Combating Pandemics.
Guy, can we ask a quick question?
Of course, by all means.
So, Don, can you talk a little bit about you talked about the districts, right? That you had 30 districts. You had 2,300 or 2,400 different geographical segments. Can you say a little bit about those districts? Was there any geographical logic for them? Was it behind it? Was it according to city lines, something that is defined by the Ministry of Interior, etc.?
Yes, the 30 districts, first they have to have a geographical, continuous geographical pattern. And they were all, so maybe let's say in terms of Israel, so we have Ezor Statisti, okay? And then we have on top of it, the city levels, and then we have about 250 regions that are more homogeneous. We looked at those 250 regions, and we try to, for the fitting, for the calibration process, we try to unify regions that are that have high similarity in terms of the socio-economic factors and the affiliation or ethnicity. Now, I say it explicitly because we didn't look at the data, like at the COVID data, when we did this unification. So the idea was to look at this 250 regions and to unify them based on their homogeneity, first, the ethnicity, and second, the socioeconomic status.
One more short question, if possible. Here.
Yes.
You had a very good calibration of the model for April and May. Did you try to predict the second wave, the third wave? What is your prediction for the future? What was your prediction for the future at that time? Was it justified? I'm really curious.
Yes, so once this paper was submitted, we didn't continue. I should say, which is very important, that obviously several interventions that happened related to the social distancing might affect the results. So I would say that I think we did capture pretty nicely these patterns, and I believe that the rest will be good as well. But I would like to note that if you'd like to have a very good fit, you won't use only 4 parameters. You would like to think in a different approach. So this approach was the standard transmission model approach. And the idea is to try to conduct simulation studies that will give you a very good understanding about some policy related questions. If you'd like, and this is what we're currently doing with Professor Bengal and our friends and colleagues from Stanford, if you'd like to identify hotspots, then what we do is actually ask questions using simple machine learning tasks that look at 1 week, 2 weeks, 3 weeks ahead. That is it, and not to ask the large policy-related questions. So I hope I gave you a good answer for this question.
Thanks. Yeah.
Okay, any other questions? So then thank you once again. So my short comments to conclude as follows. So what Don presented, and actually other people at Tel Aviv University, was before the Center for Combating the Pandemics became active. And it was evident even then that scientists can communicate good ideas or models or tools to decision makers and facilitate correct policy making and implementation. Now, what we also learned from then is that you have to be careful with what you say on public media. And this meeting now is being recorded, so I'll say only this. So we do have a mission to communicate messages to decision makers and try to affect correct decision making and better preparedness as to how to get out of COVID and perhaps the next epidemic that we hope will not come so soon. So what we hope to achieve in the foreseeable future is the ability, among other tasks, is the ability to communicate good decision-making abilities and tools to the decision makers. And I hope that two things will happen. First of all, that they will hear us, but second is that they will also listen. Thank you everybody for participating. I hope to see you in about a month's time in the next lecture of the month. Good day to all.
Thank you.